All right, we'll go ahead and get started. Hi, I'm Joel White. I'm the president of the Council for Affordable Health Coverage, and I want to welcome you to part two of our fourth annual Price of Good Health Summit. This portion of our summit covers coverage and access, and I'm excited because we have some great speakers and panelists to help us work through the different issues that we've seen during COVID. As a quick refresher, CAHC is a broad-based advocacy alliance with a singular focus that is bringing down the cost of healthcare to expand affordable coverage for all Americans. And each year we host this summit where we aim to unearth the challenges and develop the solutions that will help reverse the health cost trends that we see. And I want to thank you at the outset for our sponsors, the Better Medicare Alliance, Blue Cross Blue Shield Association, and Pharma for their support of this year's summit. Our theme this year is the pandemic, and we're taking a look at what we've learned during the past almost 2 years, how that impacted healthcare costs and coverage, access and competition, and how we can take those lessons and develop solutions that various stakeholders, Congress, and the administration might use to achieve our priorities. And we're excited that today the Assistant Secretary for the Employee Benefit Security Administration at the Department of Labor, Ali Kawar, will give the keynote starting at 12:10. You will have an opportunity to ask questions to the Assistant Secretary via the Q&A box. I think we're all familiar with how that works. Then we're going to follow up with our panel discussion that's going to feature leaders from HIMSS and HERS, Health Equity, Kaiser Permanente, NACDS, and Unum. And we're looking forward to this productive discussion. But first off, I want to level set a little bit on what we heard last week, especially from the CBO director, and some of the themes that I hope to discuss today. So last week, the CBO director reviewed how much Congress spent during its COVID relief packages, and it's a lot. He also talked about some of the near-term effects of the pandemic on healthcare, including coverage, and touched on provider consolidation and how that might be driving up healthcare costs, the impact of job loss and foregone care that could impact future healthcare trends. And our panel discussed some of the solutions to improve affordability. That included a move to value-based payments and delivery systems, more strategic application of technology like telehealth, and the need to identify the real underlying cost drivers of healthcare rather than only focusing on things like insurance reform. So today we are getting into some of the coverage issues. Because we're the Council for Affordable Health Coverage, we believe that lowering healthcare costs is the best way to make health coverage more affordable. But we wanted to kind of go through some of the dynamics that we're seeing in the marketplace. If you want to post those slides. So you can go to the second slide. And I think we all know during the pandemic, health costs remain a challenge. Over the next decade, we are going to spend about $50 trillion on healthcare. About 30% of that is wasted care. That's care that does nothing to improve a patient outcome. It's things like prescribing antibiotics for a viral infection. Secondly, those costs have grown about 2 to 3 times faster than wages. And that means that coverage is getting less and less affordable. The kind of third thing is that it'd be good if we had a lot to show for that healthcare spending, but we see high variation in quality. We actually saw a decrease in life expectancy in the US last year. Health markets are opaque and consumers really wield little power. And then on what happened specifically during COVID, we saw health spending possibly decrease for the first time in 60 years by 2%. We saw big losses in employer-sponsored coverage, but pickups in the public programs, especially Medicare, Medicaid, and the ACA. And at the same time, the level of uninsured stayed about the same. So let's dig into some of those numbers. First, just to level set where we get coverage. We still have most people in the United States get their coverage through their job. Generally, they're satisfied with that job. These are Census Bureau numbers. You can see about 2/3 get it from a private plan, including Obamacare. And then any public plan, typically Medicare, Medicaid, about 1/3 get their coverage through those. And you can see, on the right, this is 2018 to 2020. a slight decline in employer coverage, a slight tick up in Medicare and Medicaid, obviously demographics driving the Medicare coverage, but more and more people accessing Medicaid. But when we hit the pandemic, I think the interesting thing was that Medicaid enrollment really spiked and employer coverage went way down. We picked up about 11.5 million people on Medicaid. We lost probably about 6 million people on employer coverage. So really saw a shift from private coverage into public coverage. And some of the public policies were really driving that: enhanced incentives, increased funding for the Medicaid program, and making it easier for Medicaid enrollment. In fact, adult enrollment in Medicaid is up about 7.5 million through 2021. So that's a big enrollment increase for that program. And then I think that if you take a look at who the uninsured are, only about 10% of the population at this point. The really 2/3 of the uninsured, or about 30 million people, 30 million people total. 20 million of the 30 million are eligible for subsidized coverage, but not enrolled. And so I think we need to do a better job of getting folks into the coverage that they're already eligible for and perhaps have a subsidy for. But about 1/3 of people, of the 30 million, about 10 million people are not eligible for subsidized coverage and are uninsured. If you want to go to the next slide, you can see this graphically. So about 1/3, or about 10 million people, remain uninsured. About 13% of those are unlawfully present in the country. And then the rest are either in the Medicaid gap states, about 2.3 million, or folks have incomes too high to access subsidies. But then if you take a look at those uninsured, the reasons that they state overwhelmingly, it's that the coverage is not affordable. But I'd also want to point you to the two significant bars on the bottom there. Signing up was too difficult or confusing, or they couldn't find a plan that met their needs. About 36% of the folks said that, according to this Kaiser survey. And right now we're in the middle of open enrollment period for the Affordable Care Act. If you go to the next slide, CAHC, along with the Health Benefits Institute, recently released a scorecard on exchanges. We took a look across 11 different consumer functions of accessibility to information to help people make good decisions about the best plan that might meet their needs, and rank them A to F, based on scores across those 11 measures. And you can see here that there's kind of good and bad. We've got A to F. Most folks are kind of distributed in the middle, B's, C's, and D's. Right in the middle there, you can kind of see healthcare.gov at 84. But where people are mostly concentrated, so take a look at Covered California or New York State of Health, really low performing exchanges, which means that people may not be getting the information they need to select a plan that meets their needs, which means they may end up over the year facing significant deductibles, cost sharing, maybe coverage for drugs that are not on the formulary and things like that. So really, we need during next year's open enrollment period to enhance these exchange products, make sure that people are getting the information they need in order to select good coverage. So, kind of going forward and taking a look at some of the policies that we see about who's covered, who's not covered, we also think about access. And during COVID, telehealth really was a relief line for a lot of folks. I think that about a 3,500% increase in the early days of the pandemic, and then it's kind of leveled off. And we'll talk about that on the panel. We've got a lot of experts who will address what's been happening in the telehealth space. But where do we go from here? Obviously, it'd be like malpractice if we didn't talk about the Build Back Better bill in relates to coverage. And you can see here, obviously, expanding subsidies to those under 400% of poverty, extending subsidies to those above 400% of poverty, eliminating the inflation index around the affordability threshold, allowing folks that are low income to hop out of employer coverage and access ACA, even if the employer offers affordable coverage, is a significant policy change. Providing reinsurance funding or funding for state-based reinsurance programs, which we've seen The various states that have tried reinsurance have really been able to lower premiums and attract more insurers back into the market. So this bill would provide it for the individual market, not the small group market or the large group market. And then finally, resources to navigators to educate people on how to enroll in ACA plans. Importantly, those funds can't be used for non-ACA compliant plans, including association health plans and other group products. So the impact of those changes is really significant, about $500 billion over the full 10-year period, even though the policies are only for a couple of years. And that $553 billion buys about 4 million additional lives covered, largely through increases in Medicaid and the ACA market. Kind of comes at the expense of the employer market. About 3 million people would lose their job-based coverage and probably pick it up in Medicaid or ACA. I would note again the number of people possibly eligible for Medicaid in those non-expansion states, about 2.3 million. This expands Medicaid even further than that across those all the states. And so, at the end of the day, we'd still have about 23.6 million people uninsured out of the 27.7. So that's a bill. We don't know the outcome. Obviously, it's going to be debated. It's hotly contested. We're going to talk a little bit about that. I assume we'll hear from the Department of Labor on that as well. But if you think about the different markets where people get their coverage, mostly in employer markets, and then in Obamacare, one of the markets that's been largely ignored has been the small group market. If you go to the next slide, you can see that insurance coverage is really heavily correlated to firm size. So if you're working for an employer with 200 or more employees, 99% of those people have an offer of coverage. And then you go down to the next line, and that is smaller firm size. And you could see there down the bottom, if you're under 50, offer of 48%. If you're under 10, it's closer to 30%. And that is significant. So what would we do there? One of the things that we put on the table for CAHC, if you go to the next slide, is taking the existing Affordable Care Act credit for small employers, small businesses, and really making it work better for them. Right now, we have about 4,000 employers across 3 million small businesses that are accessing this credit because there's a lot of constraints on it. What we would do is kind of blow open the doors and make it available to more employers and more employees, provide a credit of 50% of the cost of the plan, and then a fixed dollar credit to the worker to help them afford their premiums and afford their out-of-pocket costs. You can go to the next slide. So that's just one idea. I think on the Build Back Better bill, we want to fix that employer firewall, that issue where if you are under 138% of poverty, even if your employer offers you coverage, you can jump into the Obamacare market. We need to make sure that employers have their risk pools are integrated, and that it doesn't kind of disrupt the integrity of their risk pools. Secondly, reverting back to current law and allowing that affordability threshold to be indexed to inflation. Dish cuts in the non-expansion states would be fairly devastating to low-income people. Expanding the existing small business tax credit. I think we should have a reinsurance program for the small group market. It's worked well in the individual market, and we ought to put funding there. We're going to get into account-based plans. Cobra Subsidies worked well during the pandemic when we had tens of millions of people lose their jobs but didn't have assistance to help afford their Cobra premium subsidies. We ought to make that an automatic byproduct of any economic downturn going forward. We need the better exchange tools, and I showed you the scorecard. We need better choices, better information to make better choices, and then permanently expanding telehealth flexibilities and making sure that we have a national licensure framework to ensure that doctors can deliver care regardless of geographic borders. So that's a lot to talk about in terms of coverage and access. But right now, I'm really excited that we get to hear from Ali Kawar, who, as I said, is the Assistant Secretary for the Employee Benefit Security Administration. Department of Labor obviously has jurisdiction over the Employee Retirement Income Security Act, ERISA plans, and large group coverage. Mr. Kawar was named Acting Assistant Secretary for his role and has extensive government experience, previously worked in a variety of roles at Department of Labor, including as EBSA investigator, worked in the Office of Enforcement, Chief of Staff under 2 different administrations. He's got a bachelor's degree from Johns Hopkins, law degree from Emory School of Law. And we're just really happy that you could join us today. And I would turn it over to you. Thank you for being here.
Thanks, Joel. Really appreciate the invitation and the opportunity to speak to all of you. So I want to talk to you a little bit about, I think, some of the lessons learned from the experience that we're still going through in COVID and some of how that impacts how we at EBSA think about the employer-sponsored universe. And the first thing I want to talk about is DEI issues. And the reason that's, I feel like, a big and important starting point is that when I think of this administration, Joel mentioned I've worked for the federal government in the past. I've actually worked in the Bush, Obama, and Trump administrations as a civil servant. And I think that this administration's priority on issues around diversity, equity, and inclusion is really unmatched compared to what I've seen in the past from presidential administrations. And it's important because, you know, when we're thinking about the impact of COVID, I mean, we need to really keep in mind what COVID has meant and the disparate ways in which it's impacted different communities. When you combine that with the importance that this administration places on DEI, it gives you a sense of kind of how we approach some of these issues. And what I want to focus on is mental health and substance use disorders, because I feel like it's a microcosm of some of the issues that we see across the health universe. Now, you all know that there was a mental health and substance use crisis in this country before the pandemic hit. But one of the things the pandemic has really laid bare is the ways in which, again, there's that disparate impact for different communities. And the mental health crisis also is kind of landing differently for different communities. We know that having a mental health condition puts you at risk for worse COVID-related outcomes. And there is that kind of bidirectional association between mental health and COVID. And when you think of the issues around what COVID has meant, social isolation, having to, you know, experience anxiety and stress, job loss, all of those kinds of issues create this kind of perfect storm for both substance use and mental health, people that have both mental health and substance use conditions. And it becomes, I think, an important way to think about all of these issues because, you know, when we see spikes from, I think one statistic that I saw suggested that 1 in 10 US adults experience depression in like a 6-month period or something like that pre-COVID, and that jumped to 4 in 10 US adults during the COVID period. It really kind of lays bare some of the issues that we're thinking about and the importance of having access to healthcare. Again, I'm just using mental health and substance use as an example, but I think one of the things that I've observed is that across the board, there's a different recognition of the importance of having access to healthcare and the importance of having access to affordable healthcare than there was before the pandemic began. In the mental health context, that's been combined with I think, silver lining of COVID, in that, you know, the stigma and the lack of awareness and general lack of support for treatment that may have existed in the past isn't really the same as it was. I think people are far more likely to talk about the mental health or substance use condition. They're far more likely to be supportive of someone getting treatment. And they're far more sympathetic in general to the needs of people with mental health conditions and substance use disorders. But again, this is just one example of how these issues have played out during the pandemic. It's an incredibly important one because, again, when we're thinking about COVID in general and bringing up this DEI point again, we know that for minority communities, for Black and Brown communities, COVID has landed very differently. We know that when we look at the mental health impact for women and minority communities of COVID, again, there are disparities there. When we look at coverage rates, again, we see disparities. And I think thinking about the mental health issues and the DEI issues are a helpful frame in just kind of identifying where there's work to do and what the path forward might look like, because there is still work to do. And there is, I think, a lot that the Department of Labor can and plans on doing on those fronts. So thinking about the pandemic itself and some of the steps that we've taken, there are obviously a number of things that we've done, which you may or may not be familiar with. I mean, the first is thinking about what we call disaster relief, which was extended during the pandemic and is currently on its way to winding down. But the extension of deadlines for employers and participants, and thinking about things like Cobra elections, disclosures that you need to provide to participants. And that was an important part of addressing some of the challenges that people faced as they transitioned from, a physical workplace to telework. There were also relaxations. Joel was mentioning telehealth and relaxations of the telehealth requirements and treatment of telehealth as an accepted benefit for the course of the public health emergency. And those were important steps to take. But there's also been important legislation that I want to talk about. The Cobra Subsidy, I think, is a really important thing that happened. We worked on a similar program after the American Recovery and Reinvestment Act passed about 10-ish years ago. But that program contained a 65% subsidy that the Department of Labor played a key role in implementing. It was, we thought, a very successfully implemented program. As many of you know, one of the big challenges for individuals
looks like we're having a technical difficulty. We'll see if we can fix this ASAP.
I think I'm back.
You are back.
Not sure where I left out or what happened. Of course, that's the first thing that's ever happened on Zoom.
You were just getting into the Cobra subsidies and
Yes.
How important that was.
Yeah, so I mentioned, hopefully you heard this part, that under ARA there was a 65% subsidy. And we know that one of the challenges that individuals face in accessing Cobra is the cost, that 102%, and the sticker shock associated with it, and the times when they may not have access to liquid assets. Again, thinking about the DEI aspect of this. And when you look at savings rates in general and the ability of individuals to afford short-term significant costs and whether or not they have rainy day funds or something like that. Again, we see disparities when it comes to issues of race, for example. So under the Rescue Plan, the American Rescue Plan Act, there was again a subsidy program that was created that the Department of Labor played a key role in implementing. That program had 100% subsidy. And we don't have the statistics yet. The Treasury Department, we're hoping will be able to eventually tell us what the take-up rate looked like. those of you that are less familiar with it, I'll tell you that the way the program worked, it essentially created a refundable tax credit for the employer to later regain in their tax payments. So we don't have the data yet to know what the take-up looked like, how different it was. One of the things that I think was interesting from our perspective is that when it was a lower subsidy, we actually did see more disputes between plan sponsors and individuals that were eligible for Cobra over whether or not they were eligible, whether they committed gross misconduct, those kinds of things. We didn't really get that same volume of inquiries, the same volume of individuals saying that they weren't able to access Cobra. So, you know, part of the success is something that we know, and we're, I think, waiting for a little bit more information to find out the rest of that story. But one of the slides I caught that Joel had up was focused on essentially issues around education, and that one of the difficulties that members of the public face when they're deciding about coverage is a lack of understanding and lack of comprehension about the products that are out there and the products that are available. One of the things that we did, and again, this brings back this DEI point, we received a supplemental appropriation to implement the Cobra Subsidy. One of the things that the law called for us to do is to engage in outreach and education of that program. And so we had to stand that up relatively quickly because the subsidy was time limited. It expired essentially at the end of September. And so we did something actually that we had not done before, but that we think is quite important and part of how we think about issues around outreach and education as we move forward and think about ways that we can be supportive of the employer-sponsored universe. And that was to engage with a contractor with culturally competent expertise that could really help us to identify where there are disparities, identify segments of the market that might not receive the kind of messaging that we typically send out, and help us come up with educational materials that would be more targeted to that audience, in addition to kind of the general stuff that we would ordinarily do. So we did have, you know, our what I will call our standard government kind of marketing stuff. And then with the help that they provided, we were able to kind of lift up the quality and standard of that material, but also think about differently issues around our Spanish language materials, and have a better understanding, not just of the way that we would traditionally approach it, which is just to translate or transcreate those same materials in Spanish, but have someone that really had expertise in, okay, for someone that is primarily a Spanish speaker, what are the messages that are going to be most, that will most resonate with those individuals, and how can we make sure that we're crafting a message? And is it or isn't it the same as something that you would do for a native English speaker, for example? The contractor also helped us in identifying mechanisms to use social media, Facebook targeting, those kinds of things. And the goal really was to get the word out and make sure that people understood that this was in a time when, you know, the economy was, a lot of people had separated from their jobs. A lot of people were eligible for Cobra. Make sure that that population was fully aware of the presence and their ability to take advantage of the subsidy. The program, I think, from my perspective and our perspective, was very successful. When we look at things like the click-through rates and the engagement that we had, it's far higher than what we normally experience. It was also far higher than the industry benchmarks that we were using. So we think that that's a very effective technique for us, and it is something that we're going to be thinking about and focusing on and trying to utilize as part of the arsenal of tools that we have ahead of us, because it's not just kind of engaging with individuals. One of the things we also think about and have spent resources on and time on is educating employers, not just about their rights and obligations, but about, you know, what it means to start an ERISA plan, and the options that are available before them, and trying to encourage employers, because you We know that most people have their coverage through the employer. We know how important the employment-based mechanism is for people to have access to benefits, certainly on the retirement side, the welfare side, but also on the health side. So we want to make sure that we're thinking about the ways that we can learn lessons from that Cobra COVID DEI experience and replicate that in other parts of our program. And I think that that's something absolutely you can expect to see from us as we continue to move forward. The other thing that I wanted to talk about is, of course, I mean, there were, I focused on the employer market, but obviously HHS has a lot of equities in this space as well. And there was also an exchange subsidy. The Build Back Better legislation that's currently being considered also has subsidies built into that. And one of the, I think, goals of the members that are working on those issues is to ensure that we can try and address some of the coverage issues by focusing on some of the affordability concerns that individuals have. Again, I don't have data on what the exchange subsidies meant for coverage as a result of the rescue plan subsidy, but it's again something that we're going to be very interested in seeing better data on. And then the last thing I wanted to talk about is, we've done a lot of thinking about COVID, and again, particularly through the lenses of DEI and mental health and substance use. Those are very, I found to be useful proxies for how we can be thinking about these issues more generally. But we're also very active in trying to work with the system that we have and putting out regulations to enhance transparency in particular. And as you know, in the Consolidated Appropriations Act, there are a number of different provisions that are focus on surprise billing, but there are also transparency provisions. And there were the Trump administration's efforts on transparency, as well as what this administration will be doing to implement the remainder of the No Surprises Act over the coming years. And those, I think, are going to be an important part of this conversation as we move forward, trying to make sure that we are being very cognizant of issues around affordability, issues around transparency, as well as issues around, how are we promoting equity with the steps that we're taking? How can we take that into account? A lot of this, I think, isn't just rulemaking, but does fall on the work that the Department of Labor and other agencies do around educating consumers and educating for the Department of Labor employers about some of the options that they have in front of them and encouraging them to be part of the system if they're on the sidelines right now. But the need for coverage, I think, again, has kind of been laid bare, and some of the inequities that are in the system have kind of been laid bare. And I think those are the issues that, in addition to thinking about how we can implement the number of provisions that Congress has given us in the Consolidated Appropriations Act, No Surprises Act, but also in whatever ends up happening through Build Back Better. Those are areas that are going to be of significant focus for us. How can we improve the quality of the insurance coverage for people that have it? How can we, and what can we do to make sure it's affordable? And a big part, I think, of thinking about affordability is focused on issues around transparency. And we're also thinking about that aspect through our educational program as well. Are there things that we can help employers understand in dealing with their service providers that will maybe add a little bit more transparency or add to their ability to think about these issues? And the hope really is that, the hope is not that we have another pandemic, but I think the hope is that if we do face similar challenges in the future, we don't have the socioeconomic inequalities that are both fed and feed the kind of magnitude of the pandemic, because it is very troubling when you look at those disparities in minority communities. And I think that absolutely for us is a high priority and a big area of focus. And that's true of our programs across the board. But with that, I'm cognizant of the time. I apologize again for whatever it is that happened with my Zoom, but I'd love to take a couple of questions before.
Thank you. Appreciate that presentation. I just have a quick follow-on question. When you're just talking about transparency, can you be a little more specific? Are you talking benefits transparency, physician, like access to network services type transparency, price transparency? Can you drill down on that just a little bit?
Yeah, so there are, obviously in thinking about pharmaceutical benefits, for example, there are specific provisions in the Consolidated Appropriations Act that deal with that, which we're quite focused on and working pretty actively on, hoping to put out some guidance on that in the near future. But I think the way I view these issues is thinking about the employer-sponsored universe. What are the tools that we can provide employers with that can help them? And that's both kind of at the individual employer level. A lot of that I think is in the educational space. But thinking about the system on the whole, where are areas where we would really benefit from having enhanced transparency, and what steps can we take? So I think that the example that's front of mind, just because of some of the work that we're doing right now, is in the pharmaceutical drug provisions that are in the CAHC.
Got it. Obviously, an important tool that we see emerging in the marketplace are real-time benefit tools that really provide those point of care information to the prescriber, who might be able to prescribe a lower cost option for the consumer, so they don't run into friction at the pharmacy. That's really important. And I would also remind folks, if you've got a question, type it into the Q&A box there, and that'll get directly asked. But my kind of second question, you got a lot of stuff in front of you, from no surprises to the Cobra subsidy. I did want to ask you a little bit about what you're seeing in the small group market in particular. We've seen fairly level enrollment over the past decade in that market. And I know a strategy that some smaller businesses are using is to self-insure and kind of come under the ERISA banner. And there was a court case about 20 years ago that really said that states shouldn't be hindering the ability of small businesses to kind of come under ERISA. What are you seeing in the marketplace during COVID? Is that a strategy that you're seeing really gaining traction? And does the department really have any kind of views of that strategy for some employers to help them kind of lower costs and get more uniform benefits?
Yeah, so I'm trying to think. I don't know that I've seen any data, any trend data that would answer your question about what small employers are doing during COVID. On the self-insurance question, I mean, there are obviously very significant benefits that you can obtain through self-insuring or using stop loss, or kind of having some kind of hybrid model. I think where we have concerns is in making sure that the employer really has the capacity, is not probably the right word, but in some sense the capacity to really monitor what's going on and really understands what they're doing. The smaller you get in the market, I think I think the more questions I would have about why you think self-insurance actually works for you. Part of the, I think, benefit does start to peter out as you go smaller and smaller in the market. But it's an issue that we thought about before. As you probably remember, we did issue, this was maybe 2013 or 2014, we issued an RFI looking at stop loss in particular and thinking about those issues. It's not something that we're actively working on right now. I will say, frankly, a lot of our bandwidth on the regulatory side is just focused on implementing those prices. And it is, I think that's definitely not changing in 2021. I am hopeful that as we get into 2022, we can start to create some room for us to think about other issues. But certainly right now, the stop loss issue is not something that's on our radar. I'm not even kind of suggesting that it's on the list of things I want to turn to as soon as I get kind of capacity to do so.
Great. Again, encourage folks, if you've got a question, put it in the Q&A function. Let's turn to no surprises since you raised it. And obviously, when the first kind of rule came out, and there was a lot of, let's just say, input from both sides. I'm sure you received a lot of comments from Congress and stakeholders and others. This is a balancing act, right? And it's significant because at the end of the day, it's the consumer that gets protected from any kind of surprise bill. Can you give us a prognostication of how this all works out, and do you expect significant additional regulatory changes? Walk us through that timeline for the near future.
Yeah, so right now we're getting a lot of feedback on the second IFR, and in particular, I think a lot of the feedback has been focused on the issue of the QPA and how much weight that should be given, and whether or not we've made the right call on that. I think that's kind of the front burner issue right now.
For those who may not be familiar, do you want to talk about what the QPA is?
So maybe just I'll kind of lay out the bigger picture framework. So surprise billing, paraphrasing, is essentially a situation where you receive treatment, you didn't, and I think in the worst set of circumstances, you didn't because of the press of time or emergency nature of what you're receiving treatment for, didn't ask questions about where you were being taken, whether the provider you were seeing was in or out of network, whether the facility was in or out of network. And I think it's fair to say that one of the things that was motivating Congress in moving this legislation through on a bipartisan basis was those kinds of stories where someone, didn't really have, I think when you take a step back and think about it reasonably, didn't have the ability to object and say, I'm in DC, like, don't take me to GW, take me to Georgetown because, the doctor there is in network and the doctor at GW is not. And the goal of the No Surprises Act really is to remove the patient from the middle. And the first IFR, interim final rule that we issued, it really was about the circumstances where it's okay to, it's okay and not okay to impose some kind of surprise billing, balance billing. The law also created a framework for resolution of those disputes, because obviously if we're moving the patient out of the middle, the whole reason that these surprise bills are an issue is because when the provider and the payer have a dispute, what has happened is the insurance company, for example, has said, well, I'm paying this much, no more, and the providers argued with them maybe a little bit, not gotten any success, and then said, okay, great, patient, you owe the remainder. That essentially is the crux of this balance billing, surprise billing issue. And it's great to remove the patient out of the middle, but the provider still wants more money than they got before, and the payers don't want to pay more money than they think is reasonable. That dynamic still exists. And so what the law created is an independent dispute resolution mechanism where either party, and their timelines associated with all of that, either party can then initiate this dispute resolution process, can use that process to trigger essentially an independent kind of arbitration. And the second interim final rule that we issued is essentially the rules governing that process. how do you initiate the process? And a key part of this is this concept of a qualifying payment amount, which is also in the first interim final rule. But essentially, that's the part where we give guidance to these independent dispute resolution practitioners and tell them, here are the things that we think are important for you to take into account, because you're going to get evidence from a provider saying, this is what I think I should be paid. You're going to get evidence from the payer side saying, well, this is what we would normally pay, and this is what we think it is. And it is, as Joel said, a balancing act, because obviously, providers want to be paid more and payers want to pay less and minimize that cost inflation. And what we, again, I'm paraphrasing what we said in the interim final rule, is that a critically important part of this is this concept of a QPA, qualifying payment amount, which you can kind of think of as like the benchmark. It's not the only thing that matters. There are times when you're going to deviate from that. You might go higher, you might go lower for whatever reason, and there's other evidence that you could take into account. But it is an approach that's rooted in what this QPA is. So the feedback that we've gotten has, there have been some members of Congress and some stakeholders that have said, we're glad you did this. We think this is exactly what the law, in the case of Congress, the law that we wrote was intended to do. This is a kind of faithful implementation of that. And I think from the stakeholder community, also recognition that this is likely to not be as inflationary as other approaches that we could have taken. Is kind of the other supportive feedback that we've gotten. I think the second camp, which is again both members of Congress and other stakeholders, is that by focusing on the QPA and this concept, we're not balancing, but instead are picking a side. And so what we hear from the members of Congress who are in this camp is that this actually is not consistent with congressional intent. What we hear from other stakeholders is that this is going to exacerbate issues around access, for example, because providers are not already believe that they're not getting enough money. Part of why they were excited about this law is because it provides them with an opportunity to kind of reset that relationship between the insurance companies and the provider community, and that our rules essentially, again paraphrasing, our rules gotten it wrong on this score. So right now we're receiving input on that. We will be issuing a final rule at a certain point. I'm not going to prejudge the comment period by saying what we will or won't do. But obviously we did take an approach in the interim final rule that wasn't an accident. We did think about this issue a lot, and it was a deliberate decision. And so that's what's in the interim final rule. Interim final rule goes into effect right now, is currently scheduled to go into effect in January. This is also the subject of litigation. We've I think just one lawsuit at this point has been filed in Texas by a Texas provider group. So, we'll obviously see what happens with the litigation, and we will see what happens with the comments that we get in. But it's fair to say that there are very strong feelings on this issue, and both kind of supportive and opposition.
Last question, then we need to transition to our panel. It's a lightning round question, so you can answer on your personal opinion or official opinion, but you talked about the Cobra subsidy. One of the things that we advocated for that. We advocate for a permanent subsidy for Cobra during economic downturns. Yes or no? Should we have a permanent Cobra subsidy situation to help people who lose their job and their insurance?
So that's a subject of pending legislation. I'm not going to take a position on that. I will say that we now have two experiences with major economic downturns. In both of those situations, Congress has seen fit to pass subsidy legislation. I think that legislation has been implemented well, and I think it's unquestionable whether or not you think this is a good idea from a policy program. For the individuals that have been able to take advantage of that subsidy, it's been in some cases life-saving. And I think, you know, there are really interesting policy debates that you can have about any number of these issues, but it's important to not lose sight of what we're actually talking about, which in some cases are life and death decisions. So,
Well, Mr. Quar, thank you. Thank you for your comments and your insights. We really appreciate you joining us today, and we look forward to working with you in the future.
thanks. Take care.
Thank you. All right, and with that, we went a little over there, but I thought it was a really interesting discussion on surprise billing. We're going to transition to our panel now. Panelists, please unmute yourselves and turn on your cameras. And I'd like to start out by asking you to introduce yourselves and your organization, and maybe ask you to say a few words about what you saw during COVID in terms of coverage and access, and how you think that changes going forward. And with that, I think I'm just going to do Hollywood squares here and go to the first guy that I see, Dr. Carroll. You want to kick things off?
Sure, thanks, Joel. Pat Carroll, I'm the Chief Medical Officer of Hims and Hers, a direct-to-consumer company that offers kind of full scope, nearly full scope primary care for about 50 conditions. And my background is I'm a primary care physician by training and practice, a family physician for over 30 years. And then I worked in the world of Chief Medical Officer for a large multi-specialty group, then a Chief Medical Officer for an integrated delivery network, Hartford Healthcare in Hartford, Connecticut, followed by 5 years as a Chief Medical Officer at Walgreens before joining Hims and Hers in May of 2019. So we're a fully virtual company. And what we saw during the pandemic really was interesting in the respect that our business was growing prior to the pandemic, and the pandemic didn't necessarily create a huge bump up for us. Our demographic, which is primarily millennials and younger, access healthcare through our platform in a way that's considered non-traditional, and that they were accepting that model even before the pandemic. Certainly the pandemic may have accelerated a bit, but our customers really value the virtual care platform, getting a medication delivered to them, the price transparency that we provide. The one thing that I'd say changed in the pandemic, we accelerated our plans to increase scope of care as our customers needed access to care for things like pharyngitis and flu. And so we added about 45 conditions on our platform. And then what we saw through the pandemic was really this escalation of behavioral health issues, particularly anxiety and depression. So about 8 months ago, we launched anxiety and depression services on our platform.
Great. Thank you, Dr. Carroll. And next up, Warren Harbour with Kaiser.
Hi, everyone. Thanks for having me today. I'm Warren Harbour. I lead the finance and finance technology area for Kaiser Permanente here in California. My responsibility is the oversight of most of our back office systems, our capital investment strategy in this space, new investment in this area. So affordability is a big part of my job in ensuring that we use technology for that in that regard. In the area we're talking about today, this is another passion of mine, and that is how to keep healthcare costs low and things we can do in that space. So I'm glad to be here. What we saw is very similar to what Dr. Carroll mentioned. We saw a massive flood from what we call bricks and mortar delivery of clinical care to a virtual care, and frankly, I am a big fan of that. And I'm somewhat a minority in that regard, but we saw a lot of that transition by sheer demand and need and inability to have a bricks and mortar or a real in-person physician encounter. That virtual world really took off for us, and it spiked. Now it has come down quite a bit, but frankly, the good news is it it still remains more than 3 times higher than it was prior to pandemic. Even though that our members are able to now see their physicians and have better access to them personally, the good news is, at least from a primary care perspective, is that they're still taking advantage of the ability to have virtual visits with their physician, and that's really helped both the capacity of the physicians in person, as well as the cost structure too. And frankly, all surveys we've had with our customers have indicated they like it. And there's a demographic cut on that. I've talked about that several times, but the older kind of demographics are typically the ones who still want to see the physician in person, and the youngers have demanded and wanted more access to the virtual world. So we hopefully this will keep going in this regard. So I'll stop there.
Thank you, Warren. Dr. Carroll, you seen the same thing, a demographic cut in telehealth?
Well, probably 75% of our customers are millennials or younger. So that's a demographic that loves what we have to offer. So I have 3 millennials. They don't have a primary care physician.
Right.
They Google up a symptom, they look for a solution, and guess what? They want it on their schedule, not traditional healthcare schedule. So we saw that pre-pandemic, we saw that reinforced during the pandemic, and we expect that it'll continue to grow.
Well, side note, I to do a virtual visit, so I'm working on that demographic cut issue. So
thank you. Sarah, shift over to you.
Great, thanks, Joel. So I'm Sarah Rozak. I'm Senior Vice President of Health and Wellness Strategy and Policy at the National Association of Chain Drugstores, otherwise known as NACDS. And NACDS is a pro-pharmacy trade association group that represents chain pharmacies with 4 or more stores, including traditional drugstores and mass merchants and grocery stores with pharmacies. And we too have seen a huge shift throughout the pandemic, even from early on when other healthcare locations may have temporarily been closed. Pharmacy doors were held open early on and throughout. And we've seen a huge shift in how folks get access to care and utilizing their pharmacies. So we've seen recent data from the government showing that anywhere from 70 to 80% of COVID vaccinations, all COVID vaccinations, are being given at a pharmacy in the United States. About 59% of COVID vaccinations being given to adolescents are happening at pharmacies. Right now, about 152 million COVID vaccines are going through what's called the Federal Retail Pharmacy Program, a program that the government set up early on to distribute vaccination directly to pharmacies to get to the public faster. And through that group, about half of all vaccinations have gone to racial and ethnic minority groups. So vaccinations is just one piece. We've increased access to testing services, and now looking at the rollout of COVID treatment with oral therapies. I think that will be another big opportunity to expand access to care. And some of what has allowed pharmacies to play such a central role in serving the public and expanding access to care during this time has been PrEP Act flexibilities that basically have preempted state law and allowed pharmacists to operate at the height of their license and really provide care to folks who need it most. And so we have too seen, there's of course the brick and mortar and also going to where the patients are. And we've been involved in pop-up clinics and direct home visits, vaccinations at long-term care facilities, and all types of other pieces. So I think as we move forward in the health and wellness space, there's definitely, more changes to come. And it's a really exciting time to serve the public and be a part of the pandemic response.
Sarah, quick question. Are you seeking to get permanent flexibility under PrEP Act after, it's tied to the public health emergency, right? So once that expires, PrEP Act flexibility expires, something that NACDS is pushing for?
Absolutely. So we're looking to secure not only scope expansion permanently, but also payment for care services delivered at pharmacies permanently. And in the last 20 months, we've seen nearly 70 state bills that have been enacted, laws that have been enacted related to scope expansion on a wide variety of topics. So I think that's happening and more to come.
And I'd mentioned those telehealth flexibilities expire, the public health emergency expires too. So lots of stuff, policy tied to the public health emergency that goes away unless Congress does something.
Exactly.
Yeah, Michael, let's switch it over to you.
All right, thanks. I appreciate being included today. It's good to be here. My name is Mike Simons, and I've got the great privilege to work as Chief Operating Officer at Unum Group. And so Unum, not necessarily a household name, as we're exclusively focused on worksite benefits. So our primary clients are employers, about 180,000 of them, from employers of 2 employees all the way up to 200,000. We cover about 39 million workers and their families through the worksite protection businesses that we have. Those are a little different than pure healthcare. We sort of surround healthcare with disability benefits. We help employers manage their paid and unpaid leaves, provide life insurance, things like that as employee benefits. So we see the workplace as an incredibly important part of getting not just health, but overall financial wellness delivered to the average working person and their family. Our COVID experience, I mean, where to start, but I would say it's been certainly been in my 4 or 5 year career, it's been the most interesting 20 months by far. So we, start internally and moving 10,000 employees from largely in office delivery to working fully flex over about a week period, and seeing our short-term disability and leave claim volume spike due to COVID back in March of 2020 by about 57%. And so we've seen 3 spikes now with, knock on wood, we're kind of coming down here in the US across most of the geographies. That's a lot of sick employees. That's a lot of employees going out on leave to take care of sick family members. So it's had a pretty sustained and big impact. Similar to what Ali was saying in the earlier presentation, and then Dr. Carroll, you were just referencing, we see that behavioral health incidents coming through in the leaves and in the short-term disability. So we've been tracking the major causes of disability for 40 years, and this is the first year in 2020 that behavioral health became one of the top 5 drivers. And we can talk a little bit about demographics and industry sectors, because there's some pretty interesting stories in there as well. And then just lastly, and wrapping it up, I'd say one thing that we will take to the other side of the pandemic, because it's bigger than the pandemic, is this issue around helping employers better connect with and serve their employees around behavioral health. So we had plans to enter that market in 2019 and accelerated that through the period.
And Mike, one of the things that I think we talked about recently is Unum also provides a fair amount of coverage to clinical workers, correct?
Yeah, we that's the biggest part of what we do is serving healthcare systems. So, if you look at the 10 biggest hospitals in the U.S., we cover 9 of them. So we get this really great opportunity to partner with those organizations and understand the really very unique and very real stresses on those workforces. So, just to give you a quick example, if what we've seen is around a 20% increase in behavioral health claims from 2019 pre-pandemic to what we're seeing this year in 2021. That 20% increase actually doubles when you just look at health systems and healthcare providers and clinicians. So they are certainly feeling the brunt of being a frontline worker, still having a lot of care despite good work from others on this panel, a lot of care being delivered face-to-face in facility. And I think that's it's taken a real toll on the workforce.
Yeah, we'll get to workforce shortage issues. Obviously, that is a big component of access. If the doctor is not available, it's hard to get access. So, but let's go to Jody. Jody, kick things off for us.
Yeah, so I'm the Senior Vice President for Advocacy and Government Affairs for Health Equity. We believe we serve 1 in 7 consumers with respect to consumer-driven benefit accounts. We serve more than 100,000 employers across the nation. And really, with the growing out-of-pocket expenses, certainly the pandemic has created a lot of issues with respect to eligibility for health FSA or health savings accounts, health FSAs with respect to pandemic access to care, all of those sorts of issues. So very, very excited to be part of this panel.
Thanks, Jody. I think we're going to stick with coverage first because, coverage and access is the theme of the panel here. But just because we have coverage doesn't necessarily mean we have access. So we're going to hit both. But on the coverage side, I think, we all know we saw the job losses, tens of millions of people initially displaced. Jody and others fought very hard to get that Cobra subsidy in place. I talked a little bit earlier about what's happening in the small group market, increase in Medicaid coverage, et cetera. Can we maybe talk to Jody first? Should we have a permanent Cobra subsidy in place during economic downturns? What do we do in the small group market? What are you seeing in terms of innovation for some of those smaller employers? They're looking at ICHRAs or QSERAs or some other types of innovative products.
I think there's a lot of innovation available. I think the challenge is getting the advisors to understand what's available. So for most small group markets, they heavily rely on their brokers and their consultants. And so I think that's the challenge with respect to QSERAs and ICHRAs. Certainly there's a place for them. I think with respect to the permanent Cobra subsidy, obviously there's a bill in Congress. I don't know that it'll move. I think the challenge there is as ACA subsidies increase, it's a challenge, right? And so the Cobra, somebody continuing their current coverage is really important for somebody who has ongoing healthcare issues, who has, for crying out loud, it's November, right? If you're in the middle of your deductible, moving to a health exchange or healthcare.gov policy is a challenge because you have to start over with your deductible. So I think that, certainly a Cobra subsidy is helpful. We saw many people take advantage of it. Unfortunately, I think it was sort of a day late and a dollar short, if you will. It was passed kind of at the tail end of the pandemic, but certainly we've seen a lot of people take advantage of it.
Yeah, and then you brought up an important point. I think that CAHC supports ACA subsidies. I think we want to target them in a way that makes sure that people don't lose their coverage if they've got job-based coverage. That the Build Back Better changes some dynamics around the employer firewall, which means if you're low income in an employer plan, you can get into the ACA and access those subsidies, which means you're disaggregating those employer risk pools. What do we think about that policy? I mean, should we better target these ACA subsidies in the Build Back Better bill?
I'm in favor of it as long as it doesn't, destroy or impact negatively the employer market. I mean, the important thing about ACA is that it's built on the backs of ESI, employer-sponsored insurance, and so I think it would behoove Congress to really understand that the majority of employees, majority of Americans receive their benefits through the employer-sponsored insurance market. TMI maybe, but I recently had some heart surgery and it was kind of like 36 hours in the hospital. I'm a Kaiser member, thank you, Warren. Really, really shocked when I saw the bill. It was like $91,000 for this relatively simple, easy procedure. And I'm like, man, I am thankful for my employer and for employer-sponsored insurance, you know.
Yeah, and that's like you said, most people get their coverage through their employer, they like it. But we've been spending the past decade, fighting a war over a sliver of the coverage market called ACA.
Yep.
Warren, maybe talk to you about your perspective on that. I'm assuming that most of Kaiser's coverage is the employer market, right?
Yeah, I mean, our commercial market is the biggest part of it, that and Medicare for sure. And it's important that the employer-sponsored coverage still exists. I think we do a pretty good job with them, and Jody's a big fan. And in our markets we operate, I think we do a pretty good job in this space. It comes under a lot of pressure for cost. The employers are, they're smart. They look at these bills and they go, this is expensive stuff. And California, and West Coast in general it's the highest labor market probably geographically in the US, with some pockets obviously that are higher, but it's a big part of it. So they're demanding, we address the affordability equation for healthcare and reducing the premiums they pay and so on and so forth. So that's a never-ending situation, and I'm pushing back into the affordability kind of comment, but I think that's really what it's all about, is what is the equation that's going to drive the most affordability in the market for the patients and members in our case, and what equation is that? And I think there's multiple tiers of that equation. There is the employer market, but anyways, I just think that it's an important part of our business for sure. But on top of that is our obligation is to deliver that at an affordable level, which benefits everyone, not just employers. So
yeah, I think we're up somewhere around $22,000 on average policy for an employer family coverage. Yep. So very, very significant. There's a narrative in DC right now that employers want to drop coverage. And a lot of what we've been talking to with our employer members is that where you're at, with our companies and our trade associations. And maybe Mike, you can speak to this. I mean, I know you're, disability, income replacement, other types of products. What are employers doing out there, especially in a tight labor market?
Yeah, I think it's the opposite of maybe what that story is that's circulating right now, because it's a tight labor market for sure. And so I was looking at a LIMRA study just done a couple of months ago. 40% of employers are looking at enhancing their benefits across the board. Almost no one showed up looking at benefit reductions at this point in time. I think, boy, good luck to whomever was going to be trying to do that in this current market. And I think, part of it is a little bit of dislocation post-pandemic where, people are still sort of sorting what their next job move is. And so there's a little bit of lack of supply, but I think there's a longer term piece to this. If you look at the demographic story in the US, the oldest baby boomer turned 75 this year, and the average baby boomer just hit 66. So if you think about a lot of people coming through a pandemic, thinking about their life and reconsidering priorities, and to when they may want to get on to something else besides full-time work, we are not replacing the number of retirements with any margin to spare. So we're kind of a stagnant workforce. So as demand continues to increase, it's put more pressure on wages and more pressure on things like the quality of the benefits program that an employer is providing. And just make two other points. That I've seen a couple cycles like this. That what's different about this one to me is it's not just that an employer needs to use health, really strong health benefits and support to attract and retain. That's the traditional, this is what you need to do in a tight labor market. But employers are being much more strategic about what those benefits are and not just how they design them to help manage costs, but much more of a focus on what can they do to improve outcomes for their employees. Because not only do they need employees to come to work, but they need employees to stay healthy, and they need employees to stay at work. And so you take the issues certainly around physical health, but most acutely around good mental health. We did a consumer study recently, and 57% of consumers, employees, came back and said they'd missed work over the past year due to a mental illness, a lot of it anxiety and depression related. So it's kind of this dovetailing of effect where employers need to be investing in strong benefits to attract and retain, but they need to do it in a way that's got leverage around improving outcomes and delivering sort of more healthy, more sustainable, more productive professionally kind of workforces. And the thing that's probably not lost on anybody is trust is in short supply, and trust in government has got to be at an all-time low. The last study I looked at is probably 6-month dated. Institutions that heretofore might have been the place to go are no longer that. Employer trust is actually managing to it's got some staying power, and it has for a long period of time. So it's just another reason that the workplace is not only just a good place for point of access around good care and coverage, but it's coming from a source where there's more trust than in other institutions that somebody else might be into.
So, Mike, you raised a great point. You brought up labor costs. So let's go there. I see kind of 3 primary issues: driving access and coverage here. Obviously, clinical labor costs make up a vast majority of healthcare costs, and those are being exacerbated by workforce shortages. I think we can think of the vaccine mandate as being one. The other is, the behavioral health issues you highlighted and some of those things. And then the third is kind of this emergence of, kind of government policy that expanded access via telehealth and via pharmacy. So Dr. Carroll, Sarah, can we talk a little bit about, Sarah, maybe I'll go to you first. Like, we have, very expensive, maybe institutional care. But the pharmacist, you all did a report recently on pharmacy access, particularly in these disproportionately impacted communities. You threw out some amazing statistics. I mean, 70, 80% of COVID vaccines in a retail setting, 152 million through the federal retail program, half of those in disproportionately impacted neighborhoods. Is pharmacy becoming the new primary care?
Well, that's a great question, Joel. I think there's huge opportunity here. I think there's enormous potential and opportunity for pharmacy to fill that role. And quite frankly, people are comfortable going to pharmacies. They've proven their ability to kind of break down those equity barriers and be destigmatizing locations for people to receive care. So absolutely, I think there are locations where people feel comfortable getting preventive care services and not just getting vaccinations, but getting other care services. And part of that equation is ensuring that pharmacists are recognized as care providers and the services that they provide can also be covered. So there's been some action in the states moving in that direction in recent years and also this year as well. And of course, we're pushing on the federal level for that to happen too. But in terms of the report that we released, we worked with Johns Hopkins, Bloomberg School of Public Health, their Center for Health Security, to co-develop this report that kind of outlines some of the critical roles that pharmacies are playing in really reaching folks all across the country from different walks of life, not only to get them vaccination services, testing services, and other preventive care pieces too. So that's certainly an area and a direction we'd love to move into. And of course, while I'm talking about the pharmacy, as you all know, many of our members, there's the full store, and there are other types of health and wellness services available within the pharmacy location outside of outside of where the pharmacist is too. So that's an interesting space for expansion in the future as well.
Yeah, Dr. Carroll, can you talk a little bit about this labor costs and workforce type issue and how telehealth is maybe stepping in there?
Yeah, I think the big picture is this, is we've got an aging population with more needs, particularly in the chronic disease segment. We've got a crisis in behavioral health. 30 to 40% of millennials have anxiety or depression that has been exacerbated with the pandemic. And there are less people like me, right? The dinosaurs, I would say, of seeing 35 patients per day with a panel of 4,000 patients as a family physician. We're looking at shortages that are approaching 50,000 shortage in primary care physicians. So if you look at all of those dynamics, we have to change the model of care. We can't manufacture more Pat Carrolls to see 35 patients per day. What we need to use all members of the team, that's pharmacists, nurse practitioners, physician assistants, and a more efficient delivery platform. Telehealth, particularly asynchronous care, which we do probably 85% of our visits are asynchronous, provides high quality care in terms of the labor force that's needed to actually interface with those patients. We can use far fewer physicians and nurse practitioners and reach far greater numbers of patients on a telehealth platform. And we absolutely need to expand the scope of care and prescribing abilities for pharmacists. That's not just because I worked at Walgreens for 5 years where I was one or two physicians with 35,000 pharmacists. So I was in that world. But I also led their retail clinics for a while, and I was part of the strategy which brought primary care practices right into Walgreens, particularly a great relationship they have with a super group called Village MD. I was one of the early folks that advocated that at Walgreens. So we definitely have a labor crunch, but we have models, innovative models as telehealth, using the pharmacists in a wider scope of care that can solve some of these labor problems. We're just not going to be able to, graduate more physicians and nurse practitioners to solve this. We just need a different, more efficient platform. And the last comment I'll say, it's about access, but it's also price transparency. Most of our customers have insurance, but most of them have high deductible health plans. So our very recent study was fascinating. When you reach a deductible of $1,600 to $1,800 per year, you never reach your deductible. And in other words, you're paying out of pocket for care. That's why as a company, we've decided we're cash pay, direct to consumer. And if you pay $30 to $35 a month for condition to get treated, you get unlimited access to provider. And guess what? You get your prescriptions if you qualify, and those prescriptions are sent to you. Millennials love that model because it's affordable, it's price transparent, but it's also very accessible. Try to get scheduled to see a psychiatrist today. 50% of them don't even take insurance. You can get in to see a behavioral health specialist at Hims and Hers in less than 24 to 48 hours and have an ongoing relationship with them through your care journey. So it's new models of care, it's price transparency to be able to solve our labor issues.
I think Dr. Carroll raises an important point, and sorry to interrupt here, Joel, but
no, go for it.
I think everyone has a high deductible plan now, right? I mean, the fact whether or not it's qualified for an HSA or not, if you look at Kaiser Family Foundation, the median deductible today for anyone is higher than what constitutes the qualified high deductible health plan. So I think you raised an important point, and I think that's what health equity is all about. Is we believe that everyone should have access to tax advantaged accounts to be able to set aside dollars to pay for their out-of-pocket expenses, whether they are, known because I have chronic illnesses or ongoing behavioral health needs or, whatever. or they're unexpected, right? Unexpected out-of-pocket costs because of an illness or injury that I didn't anticipate. So I think that you make a really good important point that I think the delivery system is changing, and I think transparency and accountability is, key to everyone.
So, and maybe we need to decouple those HSA accounts and make it more of an actual value model. Warren, can I turn to you? So what is Kaiser's pharmacy strategy? You talked a little bit about telehealth. Is Kaiser moving into that pharmacy space to access that community-based care as a maybe more accessible, lower cost option?
It's interesting because our pharmacies are typically next to the GP.
Yeah.
They're right there. So and I thought about this discussion, and I actually just wrote down the perfect model for how healthcare should be delivered. An integrated non-hospital based organization that's got the convenience of pharmacy, has the expertise of general practitioners, RNs, PAs, and mental health professionals, and the ease of use of telehealth, and also has availability to home health. There it is.
All right.
I mean, I know that sounds really wild, but
All we got to do is,
right?
Yeah.
You think about it, if you could figure out a model that can kind of deliver that, you've covered, other than critical care and end of life and as well as, trauma, that has to be dealt with kind of hospital kind of based thing. I think that's probably 80 to 85% of what we need to be able to deliver for good healthcare.
So all we need to do is convince Congress.
Yeah, exactly.
Well,
I mean, to answer your questions, our pharmacies and physicians are pretty much next to each other. So it's quite, this is the way it works. I call my physician up and say, something's wrong. And he says, well, what is it? And I talk to him and he says, well, do this. Usually offers him some sort of therapy if it's a muscle thing, or he maybe offers a prescription. Pharmacy, I just go down and get it. So, or I visit him, he or she, and then diagnosis takes place. Here, get this at the pharmacy and do this physical therapy. And so that kind of one-stop ease of access piece is really important to our model.
That very important. I love what you wrote down. I think in many ways, right now we've got a sick care system. Most health costs are from, those preventable diseases and chronic illnesses that, the top 5% cover about 20% of the spend. One of the ideas we talked about was, how do we get to more preventive, better access so that we can prevent? But then, how are we building in some of these home-based models? Because what we saw during COVID really was avoidance of institutional care. Where do we take this going forward? How does telehealth play into that? How does pharmacy play into that? How do benefits play into that? Kind of last question as we kind of take this panel out, and I'll start in reverse order this time. So I'll go to Jody first and then work my way back around in reverse order if Jody's available.
Yeah, I think it's, the delivery system is really interesting, and I think COVID has done a lot for me personally. I mean, I was a road warrior in DC, 3 weeks out of 4. And I still remember being at the Mayflower Hotel going, what in the world am I doing here? I don't want to get stuck here, and catching a flight out of DC to get home. And that's really the last time I was on a business trip. And I think the care delivery has changed. And the interesting thing to me is, will it change post-pandemic? And Kaiser has gotten a bad rap over the years. I kind of liken it to Southwest Airlines, no pun intended, but you either love it or hate it, right? But for me personally, the Thrive, the Kaiser mantra and change has been really helpful to me in terms of taking care of my personal health. Now, that doesn't mean that COVID hasn't presented its challenges. I've waited, I got a telephone visit from an orthopedic surgeon in May of last year saying you need a knee replacement, still waiting for that to be scheduled. Warren, if you can do something about that, I'd love it. But, especially before the end of the year, before my deductible resets for high deductible, all that stuff. But that said, I think before I went into the hospital for my heart procedure, I talked with a managing physician at Kaiser who showed me the data that, I think part of the problem in the pandemic has been, what can you really trust, mainstream media versus, what's the data really say? And he showed me data and said, you got 2.5 weeks, you're going to go into a petri dish for COVID. You better get vaccinated quickly. And so, Sarah, thank you. I found a local pharmacy that was giving the J&J vaccine. So I went and got it the next day. And so I was fully vaccinated before I entered the hospital. I mean, I think the care delivery, especially, it's interesting to me when we can really be, when the rubber meets the road. It's one thing to talk policy and to kind of do our job. It's another thing when you're like real life, seeing how it works. And so I think there's a lot of lessons for the pandemic and for the changes that Congress has made on an interim basis that we need to get on a long-term basis to deliver care more efficiently, more effectively, and in a better, transparent and accountable way for consumers everywhere. So that's my plug. There you go.
Great. Thank you, Jody. Mike?
Yeah, I don't have that much to add other than I'm glad that the heart issue, Jody, has worked out well. You seem like an incredibly smart, cool person that I would love to hang out with. So really cool stories. I think you've got to. I think public policy that we sort of were forced into, we should think about long term, and the kind of the corollary for me is just what can we be doing to spur innovation? Because I think at the root of it, we really got to transform the productivity in the delivery of care. And then, like, my simple example is like, think about where there is, the most flexibility and where that shortage of talent is most acute. And it's restaurants. It's like your very retail places, and how quickly have restaurants sort of gone to a QR code that you scan, an order that you make and pay for on your mobile phone, and then you go to the counter and pick up the food and take it back to your table. And you've saved hours in time in doing that. And so it's like, okay, how do we take that kind of thought process to kind of get the maximum leverage out of the human element, these actual sort of designing the menu, designing and preparing the food. And we got to bring that kind of mindset into delivery. And I just think that the work site is such a huge leverage point there. And I agree, you got to hit it from every angle, but in the work site, you can get to people en masse through a trusted source. And with this new hybrid world we all live in, the lines between what I do at home and what I do at the workplace are really blurring. So that access point of the work site is moving beyond just the employee to the whole member of that family, whatever that family unit looks like.
Thanks, Mike. And I should have added, please feel free to add any things that you think Congress or the administration should be doing as we think about this movement from sick care to well care, and addressing some of these workforce issues and coverage issues. Sarah.
Great. So I guess I'll start with that first. So I do think there should be a focus in the post-pandemic world to make the pharmacy flexibilities that have happened permanent. So both scope expansion and also payment for those services, including preventive care. I think as the healthcare industry continues to move towards value-based care, patient-centered care, pharmacies have a pretty key role to play there. And some of the concepts Dr. Carroll brought up as well, the interplay of retail health clinics, data interoperability across partners, partnerships in the retail setting and with others, I think will continue to be really important. And then finally, I think the focus on social determinants of health and health equity will play a huge role in how people seek care and addressing prevention needs.
Great. Thanks, Sarah. Warren, you already gave us an answer. You're on mute.
Sorry, it finally happens. I'm the first one to do it. Sorry. From a legislation perspective, I agree with Sarah. I mean, access is not just it's physical access too. The ease of access to healthcare, well care is important, and if pharmacies can provide that, I'm all for it. I'm all for it. And they're advocates for health, and they're trained doctors. I mean, that's good, but I think legislation needs to be there too. I think we need it for virtual telehealth. Telemedicine has to be, legislated and has to be reimbursed as frankly a real healthcare treatment. Not this kind of futuristic one. No, it's here. And home health the same way. But I think ultimately, there's a lot of things in play here, but ultimately it's about the individuals taking care of themselves, well care, and it's going to sound Kaiser-esque, so bear with me, but a lot of this comes down to making sure that our emergency rooms are not our default healthcare provider. That is poor health in all regards, and we have to have incentives out there. And I'm stopping short of saying mandates. We need incentives out there that people will seek primary care in whatever way it's delivered, pharmacy, telehealth, or with a primary care physician. We have to have incentives out there so people take care of themselves and how unhealthy lifestyles are addressed. Substance abuse, you name it, and diabetes, a lot of things. But my point is, if we rely on catastrophic care and the exorbitant costs that go with that, we will never solve. And the general practitioner needs to be brought back into the frame of reference, what's important to ensuring, and not the only place. I'm not arguing that that's the only place, but it needs to be, instead of treated as a secondary approach to healthcare, it should be a primary approach to healthcare. And we have to bring that back into the viewpoint of how to keep people healthy so we can avoid catastrophic events that are extraordinarily expensive.
Excellent. Thank you, Warren. Dr. Carroll.
Yeah, I agree with everything the panel said. I think on just a very basic, simple level, whatever the government can do to remove friction in our systems is beneficial. I'll give you one example. Telehealth, or I just call it healthcare. We shouldn't say it's tele versus virtual, whatever. The most efficient way to do this in terms of a labor force is have physicians or nurse practitioners who are licensed in 50 states. Pre-pandemic, you had to get a license for every single state. Guess you know how much that costs? That's like $60,000 per year. This is crazy. We should have one national federal physician provider licensing requirement. That way we can take a limited labor force, which we have quite honestly, and actually put them in to states that are rural and underserved. If I'm a physician, would I necessarily get a license in North Dakota? Well, people in North Dakota need healthcare, but am I going to invest, if I'm doing telehealth, in getting one in North Dakota? Maybe not, because the volume may not be there to justify the cost of my licensing. Let's get rid of the friction. Let's look at delivery systems that are founded based in quality, but can deliver care for every state equally by getting rid of all of the barriers we've put up.
Man, thank you, Dr. Carroll. We could talk for another hour, but we're already 10 minutes over. So I really appreciate the expertise on this panel. I do want to mention that we're taking these solutions, we're putting them in the pot, we're going to cook a stew, and we're going to produce a document and use that in Advocacy for Congress. So really appreciate your expertise and your suggestions today. And I want to thank everyone for joining us for the second panel here for Price of Good Health. We hope you can join us next week, again, Wednesday, starting at noon. We're going to have Congressman Jody Arrington, Congressman Scott Peters, another panel of experts. We're going to get into some of the competition issues that we've seen during COVID and consolidation, and talk about how those might be addressed. So to learn more, go to our website at CAHC.net. And I want to thank our panelists here again today for an excellent discussion. Appreciate it.
Thank you.
Thanks.